Good afternoon, everyone. My name is Dr. Nasser AL Humaidi. I am the head of the Diabetic Foot Unit at Farwania Hospital in Kuwait and the president of Diabetic Foot and Wound Association of Kuwait. It's a pleasure to speak with you today within the Foot International MENA region meeting. My topic is diabetic foot, modern concept, and multidisciplinary management. So, as we all know, diabetic foot disease remains one of the most devastating complications of diabetes. Every 20 seconds, somewhere in the world, a lower limb is lost due to diabetes. The lifetime risk of a person with diabetes developing a foot ulcer is between 19 and 34%, and the mortality after lower limb amputation is higher than many cancers. This makes early detection and proper management not just important, but absolutely essential. The classical triad of diabetic foot pathology remains the foundation of understanding the disease: neuropathy, ischemia, and infection. Neuropathy leads to loss of protective sensation and deformity. Ischemia contributes to tissue hypoxia and delayed healing. And when infection enters the picture, the progression can be rapid and definitely severe. Charcot neuroarthropathy is another critical condition that must be recognized early to prevent collapse and lifelong disability. Several factors increase the likelihood of ulceration, including long-standing diabetes, poor glycemic control, peripheral arterial disease, smoking, previous ulcers or amputations, foot deformities, and limited joint mobility. Identifying these risks early is the first step in prevention. Early diagnosis is the most powerful tool we have in preventing amputation. Screening should include a 10-gram monofilament testing, toe and pedal pulses, ankle brachial index, plus vibration and proprioception where applicable. Classification systems such as Wagner, Texas, and the more contemporary Wi-Fi system offered structured ways to assess the severity and guide treatment decisions. Modern diabetic foot care is, without a question, a team-based discipline. An effective multidisciplinary team includes diabetes and endocrine specialists, vascular surgery, orthopedics, infectious disease specialists, podiatry, wound care nurses, orthotics and prosthetics, and of course, the diabetic foot surgeon. This team improves outcome dramatically. The MDT model significantly reduces amputation rates and definitely would shorten the healing times. The shift from slow, fragmented care to an urgent, coordinated response is one of the most important recent developments. A foot attack is treated the same way as a stroke or the same way as a heart attack. Fast triage, fast referral, and definitely fast intervention. Every hour lost increases the risk of losing the limb. Management begins with offloading, total contact cast, removable walkers, sharp debridement by removing devitalized tissue to promote granulation, infection control, appropriate cultures and targeted antibiotics, vascular assessment and revascularization, either endovascular or open surgery, moist wound care and advanced dressings based on the different wound characteristics. Each patient must receive an individualized treatment plan based on these principles. Revascularization is one of the strongest predictors of limb salvage. Endovascular techniques, including angioplasty, atherectomy, have revolutionized access to distal vessels. In complex cases, hybrid or open bypass procedures remains invaluable. The key message: evaluate every ischemic limb for possible revascularization. No patient is too far gone without any proper assessment. New techniques are pretty much shaping the diabetic foot care. Negative pressure wound therapy, dermal substitutes, cellular tissue-based products, hyperbaric oxygen therapy in selected cases, and continuous glucose monitoring for systemic control. These advancements support faster recovery and lower complication rates. Preventative strategies remain the most cost-effective and impactful intervention. Daily foot inspection, patient education, therapeutic footwear, regular podiatry visits, and early intervention would form the core of prevention. If we prevent the first ulcer, we would prevent the first amputation. So, in conclusion, diabetic foot management has entered a modern era, one defined by multidisciplinary collaboration, patient-centered care, and rapid intervention. By adopting these principles, we can significantly reduce the burden of lower limb amputations across the MENA regions and definitely worldwide. Thank you very much for your attention. I am honored to represent Kuwait in this important gathering, and I am happy to answer any questions that you may have.